Good afternoon, everyone, and welcome back. It's a pleasure to have you all with us today, and I think we have a wonderful lineup of panelists for you as well. We're going to tell you about them in a moment. If you haven't already, please take a moment to complete our pre-test. There is a little gift courtesy of ONEgeneration for the first 50 people who complete and score the highest on both the pre and the post-test. There is also a link in the chat box to that. If you don't see it immediately, scroll up towards the top of the chat box. You'll find it in there in a couple of different places, and I will put it in there again in just a moment. So we are here today. Let me move my slide here. Sorry. Welcome. We are talking about person-centered care today, and we're going to be talking to some families and some advocates on that topic. And as always, we want to thank UniHealth Foundation for supporting this webinar series, and particularly Lori Resnick from ONEgeneration, who will be talking to you in just a minute. And our panel moderator today is going to be the NTG's own Kathy Bishop. But before we get started, I just want to run through a couple of housekeeping things for you. Everyone is muted automatically. If we get to the question and answer session and you have a question that you put in the Q&A box and we need clarification, we may ask you to unmute yourself, but otherwise you are muted automatically by default. The webinar is being recorded, and we will be posting the recording on the One Caregiver Resource Center page within 2 weeks. And we will also be sending it out via email to those of you who registered for the webinar today as well. And if you have questions for our panelists, you will see a little block there on your screen that says Q&A. And please, if you have a question that pops into your head, put the question in at any point. You don't need to wait until the very end to write your question in there. As soon as something jumps into your mind, we invite you to put that in immediately. And we will be taking the questions at the end, but again, don't hesitate to get that question in there just as early as it pops into your head. If you have any sort of technical questions, again, these are not questions for our panelists or that relate to the topic being discussed. These are more technical questions. You can put those in the chat box, and we will be monitoring that as we go forward. So with that, I am going to turn this over to Lori Resnick. And Lori, take it away.
Thank you so much, Catherine. My name is Lori Resnick, as you heard, and I am the Director of Special Grants at ONEgeneration. I'd really like to welcome everyone to this webinar, Listening to Families and Advocates, a panel discussion on maintaining person-centered care throughout the lifespan. As Catherine mentioned, this is funded generously through the UniHealth Foundation, and this is our 5th of 6 trainings that we are offering in partnership with the NTG. I wanted to bring to your attention that our last webinar in the series will be in March. I'm excited about that as well. It is creating a physical and sensory dementia-friendly environment for adults. We do not have a specific date yet, but we will be emailing you when we have a date solidified, and we'll let you know. Please be aware that we will also be having the ASL sign language interpreters for that webinar for a larger reach. Next slide, please. Before I introduce our amazing moderator for the discussion, I want to tell you a little bit about a comprehensive resource for adults with IDD, their caregivers, and professionals. ONEgeneration has launched a site called the One Caregiver Resource Center. It is a centralized platform to support caregivers and adults with intellectual and developmental disabilities who may be at risk of or living with Alzheimer's disease and related dementia. There's over 200 resources on categories that include healthy aging, what is dementia, dementia in adults with IDD, effective communication about dementia, advanced planning, self-care and respite for caregivers, research and clinical trials, and archived educational trainings where a recording of this presentation will be housed. On this site, on various pages, you will have information from the National Down Syndrome Society, NDSS, where we have housed their publications. One is Aging and Down Syndrome, a health and well-being guide. There is the companion guide to that, which is The End of Life with Down Syndrome, and Alzheimer's Disease and Down Syndrome, a practical guidebook for caregivers, and we have it both in English and Spanish, as well as an instructional video. I will put the link for the One Caregiver Resource Center in the chat. I already did, but I will put it in later. Next slide, please. So without further ado, I would like to introduce you to our moderator for the discussion today, Dr. Kathy Bishop with the NTG. Dr. Bishop is a gerontologist with a specialty in aging with developmental disabilities. She works as a consultant for many organizations in the aging and intellectual disability networks and assists with program and support planning. Her areas of expertise include environmental modifications and developmental disabilities, caregiving for adults with dementia and intellectual disabilities, and issues of women with disabilities. Please join me in welcoming our moderator, Dr. Bishop, who will also introduce our panelists.
It is a pleasure to be with all of you. Thank you for taking the time to be with us. Have been very excited about this particular panel and webinar. First time we have done a panel. So we've had some practice sessions and really hope to provide an enormous amount of information from the wonderful panelists. I can't think of 4 panelists I would rather discuss this topic with. Very quickly, because you have received and do have on here more detail, Dr. Brian Chacoin is the medical director of the Adult Down Syndrome Center in Park Ridge, Illinois. He has provided medical care for adults with intellectual disabilities for over 30 years and has presented and written extensively on caring for adults with Down syndrome. Ann Hart and her husband have 3 adult children, including a 38-year-old son with autism who lives with them in Austin, Texas. In 2014, she was appointed to the Texas Council for Autism Spectrum Disorders and served until the council was dissolved at the end of 2020. Ann was on the Autism Society of the Texas Board for many years and continues to volunteer for the organization in several capacities. Jim Hudson has been the executive director of the Down Syndrome Association of Greater Cincinnati since 2012. The DSAGC, tripled in size since his tenure, has been one of the model affiliates. Mr. Hudson has a track record of being a mission-focused leader who gets things done while caring for people, being connected with individuals and organizations that work with people with disabilities and their families. Jadine Sloan Ransdell, sorry, Jadine. Jadine has a BS in special education and nearly 50 years of experience working with families and professionals in many areas related to developmental disabilities. As a former consultant and staff member to the National Down Syndrome Society, Jadine created a national conference focused on adults with Down syndrome, the first of its kind in the United States. Later, she helped develop their aging and caregiver programs. She has recently published a book, Unwrapping the Gifts of Disability, a mother's reflection on raising a son with Down syndrome. Her son, Matt, who I've and others in the NTG have had the pleasure to meet and get to know, along with Jadine, of course, is the reason that Jadine does so much work, because of what she has learned throughout her life experience with her son. She has had a passion to share that with others. It is a pleasure to welcome each of our panelists and to learn from them today. Next slide, please. I wanted to make sure that all of us had the same center point of what is person-centered care. So the definition, and I looked this up in CMS to make sure that I had some of the most experience, and especially Tom Kitwood. Tom Kitwood was the originator of the concepts of person-centered care and the importance that this is the way we provide support, services, advocacy, and just being with a person. So integrated healthcare services that are delivered in a setting and manner that is, one, responsive to individuals and their goals, values, and preferences, in a system that supports good provider-patient communication, and to make effective care plans together, empowers individuals receiving care and providers, and certainly in the context of today's discussion, also empowers the advocates and families who are supporting, loving the individuals and caring for and about the individuals. A way of providing care to people that focuses on the person's uniqueness and preferences instead of the disease, not labeling the person as the disease, but seeing the person as an individual, looking at expected symptoms and challenges, making sure we're ruling those out instead of labeling them as just part of the person, and not labeling the person based on their lost abilities, but on their capacity and the essence who each person is. Person-centered care also recognizes that dementia is only a diagnosis and that there is much more to a person than just a diagnosis. Next slide, please. I'm now going to start the first question with Dr. Brian Chicoine. I have to say, one of the gifts that I have received over the years of working with NTG is getting to know each of the 4 panelists today. And I'm just honored to be with each of you and to learn from you. So, Dr. Chicoine, why did you decide to specialize in Down syndrome? And also, as part of that question, as a physician providing care to adults with Down syndrome, what does person-centered care mean to you?
Thank you very much, Kathy, and thank you very much for inviting me to be part of this and be with the other presenters this morning or this afternoon. My journey really began long before I was born. I had a great uncle Leo who had Down syndrome, although that's not what they called it at the time when he was born in 1907. He unfortunately passed away about 10 years before I was born. So I never, unfortunately, got to know Leo, but I've certainly heard family stories. So more direct reason is when I was first in practice out of graduating from residency, I practiced in a smaller community in the northwest corner of Illinois, and 2 16-bed residential facilities for adults with intellectual disabilities opened while I was there, and I became their medical director and took care of those 32 individuals. And then about the time that I was returning to the residency where I trained to become part of the faculty, Sheila Hebine, who was the executive director of the National Association for Down Syndrome, which is one of our local parent Down syndrome organizations, she was finding that they were finding that their kids were getting good care as children, but not good care as adults. And so they asked that the hospital could start a clinic, and through a series of events, I got asked to do that, and we started 2 mornings a month, and it just sort of took off, and we've seen over 6,000 adolescents and adults with Down syndrome over the 32 years since we've been open. That's sort of the start, but why did it become so much of what I do? And really, the answer is fairly evident when you start to work with these folks. Just you get to know the people with Down syndrome that we've been fortunate to participate in their healthcare, and the answer pretty much, the question pretty much answers itself. And so, that's sort of how I got started. And then as far as person-centered care, I think that it's it really sort of, in a sense, was sort of my approach long before that I was aware that there was such a term. But it really trying to understand the values of the individual and work with them and their family to meet their health goals. And the other piece of it for me with people with Down syndrome, there's just so much we don't know. And so patient-centered care really extended to really having a curiosity to work with people with Down syndrome to improve our knowledge, and work to get that information into the hands of people with Down syndrome, their families, and other health professionals. But on a day-to-day basis, it's really about listening and being respectful. You know, one of the additional things I teach a family medicine residency program, one of the things I teach the residents is, you know, when you're just pause as you're about to enter a room and before your hand hits the doorknob, and just sort of try to leave what you got there going on in your life behind, and then just really focus on the individual and the patient. So and so that you know, that's really sort of my approach as I think of each patient encounter. And then really looking at your serving individuals. There's a saying in the Down syndrome community that if you know one person with Down syndrome, you know one person with Down syndrome. And we like to say that if you know 6,000 people with Down syndrome, you still only know 6,000 people with Down syndrome. That really each individual is unique and has their own goals and desires and characteristics, and we try to address each of them in that sense.
Thank you. Great answer. On next slide, please. It's not my pleasure now to ask Ann Hart, who has been an activist, for many years for your son and others with autism and their families. Can you tell me what motivated you and tell our audience to dedicate so much of your life as an outspoken advocate? And as the second part of that question, what does it mean to you, especially in the advocacy role or as a mother of an adult son with autism? What is person-centered care?
Okay. Hi, everybody. They said in the bio, my son is 38, and he was diagnosed at the age of 3. So I entered this whole, autism disability world in 1988, which was, before we knew much about autism, and definitely, before the internet as well. So you actually did have to talk to people to learn anything. We were lucky enough that John had good teachers and therapists and doctors overall. I won't say, 100%, but for the most part, very good professionals in his life. But I realized that I was in charge. I was, pick your metaphor. I was the project manager. I was the train conductor, whatever, resonates with you. But I was doing all that with the help of my husband, who worked full time. So once that really, sank in, I, did all that work. And then a few years later, I had some extra bandwidth in my life to give back to other parents. So I started doing that and volunteering for the Autism Society. And then over time, I realized I was working full time without getting paid. But that's another story. So it's part of it snuck up on me, I guess, is the answer. But a part of the answer to that, I can't honestly say I love being say legislative advocacy, but I'm capable of doing it. It has to be done. So I've done, some of that work as well, because somebody has to speak for people who can't speak for themselves, right? So I've done that tiny bit reluctantly, but I think, like I said, I think it's important for any of us who have the capability to do some of that advocacy work. Where I really get joy is helping individual parents or small groups of parents navigate, become empowered, gain confidence in their abilities to be the project manager for their family. In terms of person-centered care, now keep in mind, John's nonverbal. He is quite impaired by his autism. Many people with autism can take a very active role in their own decision-making and planning, but John really can't do a ton. I need to represent him, and I have to consider the big picture. I have to be holistic. His doctors, his therapists, different people who would have very important roles in his life only have to focus on their piece. And I have to consider our whole family, our financial situation, his health, his happiness, his long-term future, his friendships, his safety. That can be a big deal. I have to think about whether, is somebody's suggestion actually feasible for us, or for him? And is it sustainable? Is it even available in Texas? Some really great options that people have in other states we might not have here in Texas. And then as much as possible, I do take John's input, do turn to John for input. He does communicate with assistive technology, and we can, I can sit down and talk to him. It's a little tedious, and but I absolutely take his input into account. The last question about the positive comments, I will just say, I have become a little bit over the years kind of a cheerleader for other mothers, and I have these mantras: you can do this. This isn't rocket science, take care of yourself, listen to your gut, information is power. I mean, I could have come up with a whole, list of bullets that we could turn into some sort of pep talk for, for mothers. Because, whether they think they're capable or not, moms and dads are in charge of all of this.
Wonderful answer, Anne. Thank you for sharing that with us.
Sure.
Next slide, please. Jim, you have worked with and for families with family members with Down syndrome. How did you get started? What drove you to spend your career in this area and to continue? And then as second to that, what does person-centered care mean to you in your advocacy work and your working with organizations and working with families? How close do you feel we are to achieving that? And maybe some little tip how you've gotten to a little closer to helping achieve that. All yours, Jim.
Sure, I'm going to try to be brief. I've spent my whole career in the nonprofit world, but to be honest with you, I grew up in a time in which I didn't have a family member with a disability, and in my school system and in my neighborhoods, we weren't around people with disabilities. And then I had the privilege when I was in my early 20s to work for an organization called Young Life, and had a high school kid walk through one of our meetings who had autism and probably a few other diagnoses as well. And I just fell in love with Jim, and we figured out a way, what did it mean to support him and include him in our programs. And then over the next couple decades, I just kept having all of these wonderful interactions with friends and different organizations that serve people in the disability community. And then when I moved back to Cincinnati about 10 years ago, because my parents were getting older, I decided, boy, if I could work for any nonprofit, it'd be really fun to kind of match my skills with where my heart was really beating fast. And so I landed at the Down Syndrome Association. At the time, we had a reputation of just really caring and supporting new parents. And very early, myself and the board said, we really want to grow into being an organization that sincerely cares for individuals with Down syndrome and their families across the lifespan. And then that really has been a journey. It started probably, some of the genesis was we had 2 women with Down syndrome on our board, one in her 40s and one in her 20s. And the gal in her 40s one day said, most of our programs, they don't mean a whole lot to me. I don't want to go to a high school type dance. What are you doing for me and my friends? And this also turns personal, as I have been on a learning curve, really reflected a lot on my grandmother, who battled dementia and Alzheimer's the last 10, 15 years of her life. Watched how sad and hard that was for my mom to figure out what does it mean to support her, especially as we lived in a different part of the country. And then the last 2 or 3 years, I've dealt with watching my mom deal with her own dementia and the family trying to wrap our hands around it. And then in terms of what we do with the Down syndrome community, I am probably the least qualified expert on this panel. Yet, I know we're really committed to figuring out what does it mean on a practicable, tangible way to care for our aging adults, not just today, but in the decades to come, in a dignified, caring, and a respectful way. What does person-centered care mean to me? I echo what Brian said. I think for myself and our staff, sometimes we get frustrated when we hear people out in the community make assumptions that everybody with Down syndrome is just loving and joyful and never has a bad day. And that's just not true. Like he said, you've met one person with Down syndrome, you've met one person with Down syndrome. And so we kind of sometimes have to help people understand that some of the folks we deal with have behavioral challenges or eating challenges or communication challenges. And as our adults age, we're dealing with a dual reality that in a wonderful way, people with Down syndrome are living a lot longer than many people projected decades ago, but also just the risk factor of developing dementia also obviously is higher than the typical population. So we're really on that journey. How close do we feel like we're achieving it? My personal opinion as a non-expert on this panel is I feel like within the Down syndrome and the disability community, I've heard a lot more about the need than tangible ways to support and care for folks. So I hope that that's really where we're growing as a whole community in the years and even decades to come. Thanks.
Great
Kathy.
answer. And I still, each person is an expert, and we're all pieces of the puzzle that come together. We will get closer to achieving it together. So thank you
Thanks.
for that answer. Next slide, please. Jadine, you often express concern about the lack of knowledgeable service providers for aging adults with Down syndrome and other forms of ID. Can you discuss that concern in the context of person-centered care? And let me also say, I know you had concerns that you were on this journey because of your son, and you felt in the bio that wasn't stressed enough. So please tell us how you came to do the wonderful work you do, and then please answer the question about the concerns in the context of person-centered care.
I'm just jabbering away to myself and I was muted. I'm so sorry. Okay. I want to start like Brian did and say thank you for doing this panel webinar. And I'm just extremely honored to be on it with the people that I'm sharing this time with. I'm already getting some nuggets from what other people are saying. So my son, Matt, is 49 years old, and we were given a Down syndrome, although the term was not the same, diagnosis when it was a presumptive at about 2 days of age. When he was about 6 weeks old, we got the definitive diagnosis. Since then, he has reached I don't know. He probably has about 6 different diagnoses. The most important ones are the fact that he has Down syndrome, he has autism, and he has apraxia. Those probably have contributed the most to the challenges in his life. 10 years ago, he was given a diagnosis of Alzheimer's, which is what led me to the NTG and ultimately NDSS. But I'm sad to say, but happy to say that it was an incorrect diagnosis at the time. My concern actually starts with that diagnosis, is that too often in Matt's lifetime, medical providers have seen his label of Down syndrome and they just jump off. They use that as the starting point and they make their decisions based on that diagnosis. They see him for his diagnosis, but they don't really look at his medical history. They also don't seem to have a care to gain more knowledge in the area of aging with Down syndrome. And as Brian had pointed out, we're learning stuff every year. We learn new stuff, but there are a lot of doctors, and I'm not the only parent. I work with lots and lots of parents around the world. this is a concern that many families have, is that too many doctors, see themselves for their degree and not for their humanity. Service providers, I have concerns there as well. I have a number of service providers who work with Matt who have a strong desire to do person-centered delivery of services. But unfortunately, because there's such a high turnover of direct service professionals, those are the people who get to know Matt, on a day-to-day basis, but they don't last long. So the people who have known Matt for many, many years are the ones who are supervising. They're not involved with his daily care. And as a result, I've seen the quality of care that Matt gets over the past few years really declining. And two quick examples. One, when COVID hit, we implemented a twice a week FaceTime call with him, and it worked really, really well. And now we're, not isolated anymore, but we've continued that. But as staff has turned over, there has been no consistency in connecting with him. And just before we did this webinar, I was actually Zooming into his quarterly meeting, and I asked for the 100th time, can we please let Matt FaceTime with me? He likes to do it. The second area is his hygiene. He needs help with everything. And toothbrushing, bathroom cleanliness, all of that is very dependent upon how staff support him. And we are in the process of facing probably extraction of all of his teeth because of the poor dental care that he's received from the people who are in his home providing care to him. So those are the big concerns I have, is that we don't really look at people and their individual needs. We tend to just kind of see them for their diagnosis and are not really approaching things on an individual basis.
Thank you, Jadine. Great answer to that, and I'm sure you'll be able to expand upon it in the next few minutes. Next slide, please. So I'll do a go around. Because I can't see you on the screen, I'm going to do it a little bit different than we talked about. I will just call on each one of you to answer this question. So can you give us an example of person-centered healthcare, or care? Doesn't always have to be just healthcare. In a holistic approach, it's all healthcare. Everything we do to support a person. So person-centered care you have experienced, and what did it look like to you? Brian, maybe start with you, maybe from the perspective of a physician as well.
Sure, thank you. So I think for me, the situation that pushes me most to provide person-centered care is when someone doesn't agree with my recommendations. And so it presses me to understand the person's values and goals and why, why they might be seeing that differently, and then negotiate a plan. What are they willing, to feel is beneficial, and we can really have a discussion about that. And then help the person understand why I'm making the recommendation that I am. Particularly in the dementia arena, I can think of situations which I thought, for example, an elderly parent or parents probably could use some more assistance at home with their son or daughter that had developed dementia, Alzheimer's, and oftentimes they're somewhat resistant to that, and I understand that. So we talk a lot about my concerns, try to find compromises, and finally be prepared. I think the last piece is a big one, is be prepared to be there for people when it does, what I would see in this case, sort of the inevitable happens. And so really to try to, to be there to assist them as things, progress.
Great, thank you. Anne, please.
Sure. A big part of my job, especially as I'm realizing John's moving into adult, the adult medicine, finding doctors that will work for him and that who I can work with become a big part of my job. It was the pediatric medical world just was easier for all kinds of reasons. So finding a primary care doc for him, a dentist for him, a neurologist for him in the adult world who would, accept Medicaid. I mean, like that alone was, a challenge. And I'm happy to say that as of this moment, he has all those people. But even when I've, connected and, whatever, gotten him on somebody's practice and gotten an appointment, which could take a while, I still consider those, no offense to Brian. I wish I could take him to Brian, actually. But, yeah, I still consider doctors my partners, not my superiors. So I treat doctors with respect, but not necessarily submission or fear. And I assume they treat me the same way. So that's a huge part of it for us, is that consider them, doctors and all his profession, people on his team, a partner. Recently, so if we have time later, I can tell you kind of about how we've approached the residential piece of all of this. But recently, I have brought his primary caregiver outside of my husband and me into that whole conversation. And whenever possible, she goes to the doctor's appointments with us or does the telehealth visit with us, because she spends almost as much time with John as I do. And she might see things that I don't see or have a different perspective. And I think he ends up being, cared for holistically better with that going on.
That's amazing with your primary, taking that time. That's really a great partnership you've developed. What you talk about over my many years of working in the IDD field, the transition from childhood and out of school as well into adulthood has always been met with the challenge of finding new healthcare providers and finding very few. You've done great work to get as many as you have. That's great. Thank you, Anne. Jim, next.
Yeah, I'll share a very recent win and story that I can pass on. Just even a week ago, we had an old board member come and talk at our board meeting about their engagement in our aging programs. And John and his wife were taking Garrett, their 39-year-old son, to their family doctor for years, and it was this level of care was just okay. And because of his connection with our aging programs, we did a workshop which exposed a lot of our families to the Freeman Center, a clinic out of UC Health that has developed in the last couple of years to serve specifically people with intellectual and developmental disabilities. I've had the privilege to be on their advisory board and know the medical director very, very well. And we've been a big champion for them. And, John couldn't rave enough about what his first medical visit was at the Freeman Center, because he was actually sitting with a team of people who really wanted to listen to them. Garrett is nonverbal, but they had a social worker there and try to really understand their needs. And in the last 6 months, I feel like they have much better care for Garrett than they've had for decades, kind of previously. And I think it just filled them with hope that they're going to be in a place now where Garrett's individual healthcare needs and even other needs could sincerely be met. So that was a great win.
Thank you, Jim. Wonderful. JD?
I think I love sharing this example of person-centered healthcare. Matt's insurance changed a few years ago, and we couldn't stay with the primary physician that he had, and just somehow or another ended up with the one he currently has. Matt's first visit, new patient visit, he spent maybe 15 minutes or so with the nurse doing all the preliminary stuff. And then we sat in the exam room and the doctor came in and he went through screen after screen after screen of Matt's medical history. And I ended up having to go get my car out of the valet parking because it was turning into after hours. That man spent 2.5 hours, the doctor, with Matt and me and a provider that was with us, asking questions, listening to, like he asked about, the Alzheimer's meds, because, we had that Alzheimer's diagnosis, and I explained to him why I did not want Matt, taking Alzheimer's meds. And he was so considerate. He spoke to Matt, not just to me. And Matt does not speak, he has apraxia, so he's not a verbal communicator. But he just made us feel so comfortable that when he asked that we switch Matt's ENT to a doctor that he was used to collaborating with, and I really didn't want to. And then I thought, this man spent 2.5 hours with us learning who Matt is. The least I can do on this medical team is to go to hit the ENT he prefers. And if it works, great. And if it doesn't, we'll figure it out from there. But I know that's very unusual, but it has made such a difference in how I feel Matt's healthcare goes, because that's the one physician who sees Matt the most. He also does a really good job of making an attempt to collaborate with the other specialists that are on Matt's team. Some doctors work better with him than others, but it has nothing to do with his ability to, he's making the effort. It's just, some of the doctors Matt has are just kind of that they're giving okay care, but it's not necessarily the best one. But yeah.
Wonderful example, and great that you had that experience. Have had a question
Kathy,
in
could
the.
I add one other thing that I
Of
wanted
course,
to kind of
please,
piggyback
please.
on what Ann said about the primary staff going sometimes to the doctor's appointments and stuff. I'm in the process, as a 76-year-old parent, I'm in the process of learning to let go. It's been one of the hardest things that I've done in raising Matt and caring for Matt and loving Matt. But I have a couple of people on his team who they have become like family. One is like a daughter, and the other is quickly, we're going through the adoption process with him. But he takes Matt to all of Matt's medical care now. And the wonderful thing is that before they go, Brian calls me on the phone and says, okay, we're seeing this doctor. Anything that you have concerns about, you want me to find out about? And then when it's over, he FaceTimes, and, Matt and I get to FaceTime, and I learn about how the appointment went, if there's any changes and stuff. That has been just so crucial to me being comfortable to becoming an older parent, not knowing where the future's going. So, I value that he takes that care and really knows Matt. So, yeah.
Great. I'm glad you
Thanks,
added
Kathy.
that. Great example. Not a problem at all. That's why you're here. There was a question, and I won't give the full question till the end, but one of it was, how do you provide person-centered care? And how does that affect segregation? Doesn't that create segregation as part of it? I just want to point to, on the right side of the screen, the visual there that really shows the parts of a person-centered care, which means enhancing dignity, honoring choice, improving quality of life, empowering residents, supporting independence, and promoting well-being. And if you think about those factors, then you start to realize there's nothing in here that says, because you're individualizing this and honoring the individual person, valuing who they are, doesn't mean you do it in the context of the person being segregated or alone. So just wanted to point that out in the context of this visual, and then we can move on to the next slide, please. So what recommendations do you have for person-centered care for adults with IDD who are living with dementia, with people that have most likely had an accurate diagnosis of a type of dementia? And so, Brian, I'll start with you from your perspective as a physician.
Great, thank you. So, I think person-centered, for someone with dementia, I think person-centered care really, it really pushes the button to provide person-centered care. First and foremost, the person has value, even with the, the diagnosis of dementia, and deserves attention and deserves, appropriate care. And then I think it really is looking at the individual, again, not just as a diagnosis, but looking at the person's individual, and what can we do to help that individual optimize their function and have the highest quality of life that they can, while unfortunately, acknowledging that they do have dementia and dealing with that appropriately. And then particularly in Down syndrome, one of the things that's so important is to keep in mind that Alzheimer's disease is not the only diagnosis, and that there is potential for other co-occurring conditions. And so if the person has one of these other co-occurring conditions, we can address that and help optimize their health and help optimize how they feel and their function, et cetera. So I think that's a real important piece. So just to be careful to not assume that it's all Alzheimer's disease, that there may be other things that need to be addressed. But I think the other thing that with patient-centered or person-centered care, it in a sense with our patients or with people with Down syndrome, it really goes beyond the person. So in a sense, it also is family-centered care, because the family is typically such a big part of the individual's life, and especially the parents. This is and our folks with Down syndrome, it's really a very unique entity in that parents are taking care of a child with dementia rather than a child taking care of their parents with dementia. So it really is a very unique situation. And so and many times you have perhaps the person with Down syndrome is in his 50s or his or her 50s or 60s, and the parent may be in their 80s or 90s. And so really, what do they need in addition to what does the individual need is a very important piece of what it really ends up becoming the family-centered care for these individuals.
Very interesting answer, and one that we don't think about. Once had someone say that we do a lot of talking about helping families understand when their family member with an intellectual or developmental disability has a dementia, but we haven't done a lot of work, or what do we do working with a person with IDD, understand that their parents are experiencing this disease. So great that you brought up that dynamic. Thank you. And so moving on to Jim, same question, but certainly from your perspective.
I've thought a lot about this and just our role as an organization. At the end of the day, we're probably a family support organization that tries to support families along their journey. And I think there was 3 quick things that came to my mind. Number one is get educated, and this is not a fun topic to talk about. And I find oftentimes families are kind of in denial about some of the challenges around possible dementia diagnosis and where do they go from there. But whether it's NTG, the National Down Syndrome Society, this one caregiver, there's a lot of materials out there. But sometimes it takes responsibility of the individual parents or siblings to really go out there and try to understand what they may be seeing and feeling and sensing in their loved one with Down syndrome. The other one, and I'm dealing with this in my own family, is push through the denial. It is easy for us to be in denial about some of the things that we're seeing in my mom, and it's easy for other families to be in denial about some of the things that changes they might be seeing in their loved one with Down syndrome or other developmental disabilities, and would encourage people to push through that and to be proactive. I always find whatever the challenges the families we are working with are facing, the ones who are proactive are the ones who show the most resilience in working through those challenges.
Wonderful. Great suggestions and thoughts. Thank you. Anne, all right, sorry. Well, Anne, let's go to you next. Because we're talking a lot about people with Down syndrome, and in terms of people with IDD, people with Down syndrome have been the most researched, and the most is known about aging and some risk factors. Not that there's not a lot more to learn, but I wonder if you could also answer the question about your son with autism from the perspective of there is far less known about aging risk factors, and making it even more difficult to think about what access do you need for services and what do you need to do for future planning. So Anne, if you could kind of take that perspective, it would be great.
Sure. I think in the, autism advocates see this kind of as the new frontier. We not that early intervention is perfect, or, behavior strategies for elementary school children. None of it's perfect, but we know a lot about early intervention. We know a lot about best practices for children and even teenagers. We don't know much about, that long-term future that you're talking about. But I will say, when I went to the NTG's training in March of last year, the train was like a 2.5-day training in Dallas, mostly focusing on much more about Alzheimer's than IDD for me, or that was the new part. That was the new part for me, was all the Alzheimer's information. And what I kept noticing is that many of the best practices for Alzheimer's were things that were pretty standard in the autism world already, or certainly things that I had heard, forever, like behavior is communication. That was one of the first things anybody ever told me, back in the late 80s. And it had nothing to do with Alzheimer's, it had to do with autism, but it carries over. Likewise, the making environmental adjustments and having all kinds of visual aids for the person. That's pretty standard for, even little kiddos with autism. So that was, that was consistent for me, and that was natural for me as a parent. The goal will be to take those strategies, say, to a group home, or something like that, to people who didn't grow up with, haven't been in this for many years. Routines and schedules is pretty standard for us in the autism world. Talking to people who don't talk back, or might, take a while to process, but you talk to them in a regular way as much as possible. And then also considering sensory, could this be sensory? Could this be a stomach ache? Like always trying to cover all your bases when there's a new problematic behavior. Again, that's pretty standard in the autism world. And it seems like those are best practices in Alzheimer's. So, not to say any of this is easy, but it may be, for an autism mom, maybe it would end up being, it's like, yeah, okay, yeah, I do all this already. This is kind of what I'm used to, for better or for worse. I had one other thought, and then giving the person choices as much as you can, like maintaining, even somebody who's very severely impaired, trying to find opportunities to give them agency for, over their life. I think that's certainly something we preach in the autism world. So, I hope I'm right. You can feel free to push back on all that.
No, your perspective is exactly right on, Anne. In fact, a lot of the work I've done over the years of trying to understand how to modify environments for people with ID and a type of dementia, the sensory issues, I've learned from the autism world, from the work of people who have autism and are able to communicate, people like Temple Grandin. And I'm glad you added that perspective, because it's been a great learning how much that can help other people.
Yeah. And I guess, so that, that's all just kind of on a personal level. But I think to the challenge is scaling that, and then that always gets back to advocacy, right? That gets back to the activism and being a squeaky wheel and being loud and just kind of sometimes nagging and repeating, and that's just part of it. And if you're going to change a system, instead of just keeping it at the micro level.
Great, thank you. Excellent. That really has added to our conversation. Jadine, the same question.
I think number one for me is because Matt had so many challenges in his life, and too often professionals were very quick to see him as a behavior problem or a bad kid. I want people to see Matt as the amazing person that I know, who has needs and desires and, yep, some quirks, just like the rest of us do. To me, that's the most important thing, is if you take the time to get to know Matt, well, all I can say is any of the staff who have taken the time to get to know Matt actually fall in love with Matt and want to continue to work with him. So to me, that's critical for everybody that we serve. Get to know who they are as a person, not as a diagnosis. Another thing is to just be open to learning from our loved ones and from our family members. We're the ones that know the person best. I have had to be a strong advocate, and I think Anne is probably in the same boat that I'm in, because Matt can't advocate for himself in a way that everybody understands. So I have to speak up for Matt. And when I do that, I'm not doing it trying to be critical of whoever's working with him. I'm doing it trying to give Matt the best life that he deserves to have. So, I'm an outspoken parent, and I'm very much a collaborator. But sometimes I do have a cup that says I'm a mama bear. So, I don't know if you all have checked out the stuff on the internet about mama bears. It's not real nice, and mama bear can come out once in a while. So the other thing that I think is important is whether it's parents or siblings who are providing care, whether it's direct support professionals, whether it's our medical providers, that the more we can take advantage of opportunities to learn and to grow in this area of folks aging with developmental disabilities, because the reality is we're pioneers again. Our folks are living longer. I have a friend who just posted in my Facebook support group that her sister just turned 66, and it's like, oh, this is so amazing. It's amazing. So I think just staying up with the new information that people like Brian find out when they do research and stuff, that's how we're going to make a difference and make life the best that it can be as our loved ones are aging. And I'm into some serious contemplation about some significant systems change. I've been talking with folks at NDSS for a few months about how can we make some changes to support our families and stuff who are, still caring for their loved one as the parents are in their 80s, the siblings are in their 60s, the person with Down syndrome is in their 60s. We need to do better. So that's it.
I love the perspective. I think you add a great perspective. The other I really like in your writing of your book of having a son with Down syndrome, seeing as a gift and a gift that has shaped your life for the better. And so I love that perspective from you.
Thank you. Thank you. He definitely did.
Good.
And continues.
Next slide, please. Oh, and continues, I know. Next slide, please. And it's interesting because we also got a question in the Q&A. Can you make some recommendations for futures planning And so it fits in a little bit into this slide, and what trying to get at, what do you see for the future? Do you have concerns? What would be your fondest hope or dream? And do you have ideas, such as you mentioned, already talking with NDSS, Jadine, to think about how you can make those hopes and dreams a reality? Jim, let me go to you first on this one.
Yeah, and I'm going to speak as a nonprofit executive director here that supports families. I think my number one couple concerns is just the denial of people not wanting to really kind of face the reality of potential challenges. But with that is also, I'm concerned about the assumptions. Oftentimes people think, well, everybody with Down syndrome is going to experience Alzheimer's or dementia. And I know that's not the case either, even though I'm not a medical provider. So those are some concerns. In terms of for us as an organization, our fondest hopes or dream is we're seriously doing the business due diligence of what would it mean for us to design a day program that we would start that would take the best practices of day programs for people with developmental disabilities with the best practices of what people have done in terms of doing day programs for seniors dealing with dementia and Alzheimer's, and how to bring those two together and really kind of pioneer something that hopefully other people around the country can really kind of mimic after we kind of go through maybe some painful learning curves for a couple of years. How to make those a reality is probably means I don't have to go raise a bunch of money. It also probably means we have to make sure it just makes business sense. But
you talk with your families already about futures planning?
Yes, we do. And we're actually bringing in Kathy and Catherine to come and speak about this topic in April because it's so important. We're investing the money now. We will work really hard to make sure people come and listen to something that won't be fun for them to hear, but it's really important for them to hear. Part of our mission statement is to educate families, and we know this is an important topic that we need to educate families about.
Yeah, we're excited and looking forward to it and honored to be asked. And hopefully we'll at least make it interesting and not painful. So
I'm sure you will.
Thank you for asking us. Anne, next with this question.
Sure. Well, I'm definitely concerned about the future. We currently have a pretty good system in place where John is at another house during the week with a couple dynamite caregivers, and then he's home with us on the weekend, and sometimes we hire help on the weekend. Sometimes can make weekends a little boring for him because the caregivers are a lot more fun than we are, but overall it's working. We don't know if that's sustainable. I mean, right now it's very contingent on a couple just superb individuals who fell into our lives. And then when I look around my community here in Central Texas, there is not a place, that would work for John in terms of a campus-based setting. And the community-based systems, well, for one thing, we're on a waiting list for that, for the best level of funding for him, or the highest level of funding for him. And, I just worry that, for all kinds of reasons that we've already mentioned, moving him to a private group home that I'm not in charge of, or that my husband and I aren't in charge of, just might not fill his needs. Luckily for us, I will say on the positive side, we do have some discretionary money to put towards all this, which is not something every family can say. And John does have two siblings who have understood for many, many years that they are ultimately in charge. I promised them years ago that they would not have to have him live with them, but that they would be in charge of his life when my husband and I weren't able to anymore. And, so that, and again, I know plenty of, I have plenty of friends in Austin whose son or daughter with autism is an only child. So they're really, really worried. My fondest hope would be that this current arrangement works forever. And in terms of ideas on how to make those hopes and dreams a reality, I mean, honestly, I mean, I definitely love the nonprofit, you know, creating a program, and there's some really good models around the country that I, you know, would work for John. But this is this is too big, I think, for nonprofits to solve. I think nonprofits can make great, create models, like I said before, but ultimately we have to commit, you know, either a state, you know, Texas is not committed to solving this problem, but maybe as a country solve this problem. But I mean, I think this has to be, you know, more like what Jadine was saying, like we have to change systems. We have to create a safety net for all people, not just people who have some private money to spend, and, you know, getting on my soapbox. But again, you know, I mean, that's what the future is in the advocacy department. It's the new frontier. It's those of us who are there and still able to, you know, have some energy for advocacy, have to paint the picture to the people in power, who have the decision-making ability, because I'm not sure they truly understand our lives.
Yeah, I love the concept of being pioneers, which you all are in the new frontier. So great comments on that. Are you in self-directed program in Texas?
Consumer directed, yes. We are in consumer
Yes.
directed for the making, you know, hiring our own people and stuff right now. Yes. So that's and that's good for, you know, if you're able to manage all that. Yeah, it's definitely the way to go for the Medicaid waiver.
Our viewers are probably not familiar, as not a lot of states are doing that. Could you just briefly explain what that means?
Oh, sure. So John is on a Medicaid. Well, we have several Medicaid waivers here in Texas, but he is on one called CLASS, Community Living and Support Services, I think is what CLASS stands for. And basically, he has a budget and a funding stream. So he gets hours for attendant care and respite care, and then he has a couple hours of therapy a week, recreational therapy a week. But for the attendant care, that's what Kathy's talking about. We use the consumer directed option, which means that I hire the people. And the wage, I will say, the hourly wage is not very high, but by the virtue of me being the boss, and I don't get paid to administer the program, we are able to pay our attendance a little bit more and maintain more control over the schedule, the conversation, the training, all of that, you know, that you might, you know, with a different model, an agency might handle all of that, and then you just get what you get. For now anyway, and you know, there's some paperwork involved. It's not, you know, just a breeze to manage, but it's certainly within my, you know, my capability of doing the administrative piece. And it's much better, like I said, if for anyone who has the capability of doing consumer directed, it's definitely a better way to go.
Yeah, thank you for that.
Sure.
I know there are a few people who have mentioned in their states similar kinds of programs that are just organized in a different way. I do want to take this opportunity for viewers to remind you, when working with families, if families are moving from state to state, the Medicaid is not transferable, and to make sure that you advise families in their future planning for possible retirement. And for those of us who live in the North, often that means coming to the South. Make sure you connect with the state you hope to retire to, see what services are available and what is the eligibility criteria, and what's the likelihood that you would be able to receive services for your family members. So please, all of you, make sure that you're giving that advice in terms of futures planning. Jadine, next.
Yeah, my personal concern is that Matt will outlive me, and then that scares me, just because I've seen so many changes in the way services are provided here in Florida. But the other concerns I have are more global, and they come from the Facebook support group that I run for families who have loved ones with Down syndrome and Alzheimer's. And I'd like to just share something that I had written to Candy Pickard when I first started communicating with her about the need that I was seeing for system change. I wrote to her, I have heard from families who have had no support for a loved one when the father died, even though the loved one had funding for service and a provider on paper. The provider would not serve the daughter because she was exhibiting behaviors. Her father had just died. She had just been in the hospital, I think maybe for COVID, and they refused to provide services. And this family had to schedule the dad's funeral service in a 2-hour block because that was the only time they could get respite for the daughter. One shared that when the loved one required hospitalization, nurses reported the sibling for abuse without speaking with her or the primary physician. As a result, guardianship was granted to the state, and it gets much worse. And what happened, the woman with Down syndrome was thin. There was documentation of weight loss over about an 18-month period. They had been working very closely with the primary physician, and the ER chose to not follow up on that. The woman ended up in a nursing home in rehab, and then got a huge, I don't know what they're called, but the bed sore, to where she went septic, and she was then taken back to the hospital unresponsive. I do not know what's happened since then, but she was very close to death the last time I heard. And the last one was a sibling who lives in Texas, and was quite concerned because she is the only person to provide care for her sister with Down syndrome and Alzheimer's. And she herself had just received a terminal diagnosis, and she felt guilty as she thought about how was she going to live the last of her life and still provide care for her sister. There was no family in Texas with them, and there were no providers who would take a person under 60 with a dementia who has Down syndrome. So those are the kinds of things that have gotten me on a soapbox and that actually keep me awake at night, because we desperately need systems change. The comment that you made, Kathy, about the Medicaid not following the person, we've had a number of siblings who the parents have died and they live in a different state, and they can't even bring their brother or sister to live with them because they would lose services. And if they were to come to Florida, they would be 10 to 15 years on a waiting list. So I just feel as a country, we are doing a huge disservice to our very vulnerable citizens who are aging with developmental disabilities. And of course, my focus is on Down syndrome, but this is across the board. Yeah. So
Yeah,
those are my
very
concerns.
moving.
And my idea on
Please.
how to make that happen, I'm in my vision, in my head, I see a big consortium of people who care, who are committed, like Jim Hudson said. You know, I love the fact that he said, I'm committed to doing something. And it's like, that's half the battle. If we can find people who are committed to help us change how we let our loved ones live their best life until their very last day, you know, that's what we need. So off my soapbox, sorry.
I'm glad you go on your soapbox. That's why you're on here. And Brian, I'm giving you the chance to follow all of the emotional and very moving and very educational comments that have been made.
Yeah, great comments. I mean, I think clearly, you know, for the future, you know, I'm obviously in the health arena, So, when we're looking, I think a lot about health equity, and that's really a lot of what I'm looking at this point. And clearly, as Jadine and others mentioned, there are funding issues, there are advocacy issues. There are just some simple societal issues of helping some people in society see these individuals with intellectual disabilities as people. That's just some of the grassroots sort of stuff that needs to be done. And there are lots of wonderful people, as you can hear, working on that, doing those things. For me, I think that, and I don't know that I don't think I coined this term, but the term I use is equity through education with regards to health. So really, how can we, bring the healthcare of these individuals up, equitable to other people? And education, I think, is a big piece. And so, there are going to be some, prevention measures and some new treatments that are coming down the pipeline that I think we need to, again, some of those may be funding issues and, making them available to people with intellectual disabilities. Some of it's in the research arena where we don't even include these individuals in some of the studies. And so we don't even really know how the medications would impact them, or the other prevention measures would impact them. So I think really including people, in these things is going to be so important. I did notice a question in the chat thing about segregation and really the person-centered care is really the antithesis of segregation. I mean, it's really in looking at the person as a person, and it's not just their disability, it's their ethnic issues and their race issues and whatever else may be impacting that individual in getting the care that they need. And so I really think that the first step is listening, and this is an opportunity here to, what do people need? What are they not getting? And then what information do you need to help meet your healthcare goals? That I think is, for me, a big piece of it. And then how do we get that information into the hands of people with Down syndrome and their families and health professionals as well? I was reading a piece a while back on somewhere on the, I don't know, Center for Disease Control or something, but really the good healthcare as we go into the future will be about educated providers, but also educated individuals, educated patients or consumers, however you want to, whatever label you want to give people. But so really, education, I think, is such an important piece. And the reality of the situation now is, I think that particularly in the intellectual disability world, that I wish it wasn't so, but there is a lot of responsibility on the families to gather information and bring it to their providers, just because the providers don't always know, particularly in the adult world, about caring for these individuals. And the unfortunate reality is the healthcare system is stretched right now, and people who are underserved, which really is, it's been recognized by the government that people with intellectual disabilities are an underserved population. When the healthcare system is stretched, the people that are underserved already are the ones, unfortunately, that get lowest view or whatever. And so really, I think it's so important to educate yourself, and then to try to share that. And the other thing I would say, particularly in the age of the internet, I think, is really trying to be careful not to get lost in the myriad of really bad advice that's on the internet, and really try to find reputable sources. Because I think, particularly, again, I'll just speak for the healthcare system. It is stretched, and to try to sort have lots of information that's really is not does not have demonstration that it's beneficial, and just trying to sort all through that, a provider to sort all through that is very challenging. So I think really you want to work together as a team with your provider, and I think that's really my fondest hope and dream, is that we will have health equity through a lot of these other things, but in my viewpoint, through education as well, is an important piece to that.
Thank you. Though of course, the stories are troubling, the experiences are troubling, at the same time, each of you gives me hope, your passion and your commitment, and I think really will help all of us think about the ways that we can make a difference. Next slide, please, Catherine. I'm just looking. If Each of you, if you can just quickly, with expertise in your area, if you could say a sentence or two, I'm making it impossible for you, but we're getting closer to the end. What advice would you have for families on how to increase their knowledge and feel empowered as caregivers? And let me also reference that we have at the end of the slides a number of places to go to for resources as a great start. And these are good resources that have been vetted. Anne, start with you.
I
This
can
is
be
kind of a go around quickly.
sure. I can be brief. Connecting with other families is what I would recommend if I'm going to give one tip.
Perfect. Thank you. Jadine?
I had that one as well, but I think for probably all families who have an aging person with intellectual disabilities, knowing what health conditions they may face as they age so that they don't get like we did, dumped into the Alzheimer's truck before that's needed.
Yeah, can you remind us again, how old was Matt when he was first diagnosed?
39, and his diagnosis was literally, Doctor, Matt's had some changes, he seems a little confused. Doctor did nothing else. He said, well, he's 39, he has Down syndrome, he has Alzheimer's. That was how we got the diagnosis.
Yeah, and that's
Yeah.
not atypical, and something for our viewers to remember, to also work with families. Families work together to make sure that a differential diagnosis is being conducted for anyone, but especially for a person with IDD who can't report their symptoms. Jim?
First I want to affirm all the people who logged on today to watch this stuff. I think just a basic principle of learning. Part of learning is not just absorbing, but then passing it on to other people, whether it's passing it on to your providers, passing it on to other families. Don't keep what you learn in secret. And you'll be amazed at I learned a lot today by just preparing for this little presentation here. So keep the cycle going.
Wonderful, Jim. Brian?
Yeah, certainly the education that others have spoken about, but I think also sharing information with your provider. I'm part of the Down Syndrome Medical Interest Group, and we have a lot of information to share with families, with providers, and so some providers don't know about it, and so that would be something to share with them. We have something called Project Echo, and Dr. Keller from NTG also has some Project Echo, which helps providers, healthcare professionals learn more about caring for these individuals. So feel free to share that information. And then there's some additional projects coming down the pipe that I'm looking really forward to sharing at some point, that really to help educate.
Right. And Lori just reminded me of a resource that we have that is free to the public and has a manual with it. It's the EDSD. It's the Early Detection Screening Tool for Dementia. It is meant for families, lay people, and it's available on the website, which in a few minutes you'll be given the link to all of the resources we've been talking about and others besides. So really recommend that you look at that. And I will say that families, physicians that we have worked with like having it, because it gives them a good place to start for conversation and dialogue and to understand the person. Brian, you've had experience with the EDSD, haven't you?
I have, yes. Yeah, great tool, great tool.
Great, thank you. Next slide, please. Organizations, I think I'm going to just give this to Jim if it's okay, so we can move on. We do have a couple of questions from the audience. What are the two most important things, as you representing an organization, do you think that our listeners need to know about?
I know what we're taking responsibility for is, I think for years when we thought in terms of health outreach, we were dealing with pediatricians, genetic counselors, OBGYNs, on how to deliver the diagnosis. And I think we're learning that we need to take this material, just the adult medical healthcare guidelines, and go directly to primary care doctors, group homes and day programs and pass on what we've learned and what we are continuing to learn.
Great, thank you. Next slide, please. Brian, I think you've already answered this, so let's go on to the next slide.
I did.
Yeah, and we have heard a couple of questions. I guess I'm going to ask one of the panelists to volunteer to answer it very quickly. Again, it's going to have to be a couple of sentences. It's how do you provide person-centered care, individualized care, without segregating, without discriminating, and also possibly taking away some of the dignity of the person. Who'd ever like to take that question on?
That sounds like a
Kathy, this
Brian
is
question.
Jadine. This is Jadine, and I'm just, I'm pondering that based on Matt. And I truly believe that unless we do person-centered care, all of that can happen to him. And when we focus on him as a person with, who loves his family, who loves to collect cat stick toys and, has these unique, quirky pieces to him, if we don't recognize that, then we're failing him. So I believe that person-centered care helps us move away from all of that segregation and discrimination.
Perfect answer. And I see someone also put in the chat friendship as one of the answers. Next slide, please. And I'm going to put our panelists on, if you could, in 1 or 2 words, some final thoughts for each of you. Brian, start with you.
That sounds great. I think, hope has been used throughout this thing. And I think really this is about hope. It's about hope for the future where there's new treatments and understanding prevention measures that are coming rapidly. In the meantime, I think it's hope about, appreciating each day and appreciating what people can do rather than focusing on what they can't as much as we can. And then, just try to help people each day to optimize their day as much as we can.
Perfect. Anne?
I'll just put a new thought out there that we haven't had time to explore, but for all of you parents and siblings out there, anyone who's in charge of an individual's care, please do take care of yourself as well, so that you don't burn out and you're in it for the long haul and you're as healthy as you can possibly be, because you need that and your family member needs that.
Perfect.
Kathy?
JD, go ahead, please.
I was just going to say, Jadine, there's one in the chat box that you might want to just check on that's to you about your Facebook group. Maybe you can answer that one in the chat box. But I didn't want to lose the question to Dr. Chicoine on his opinion on Alzheimer's medications that was raised. One of our participants said they were told by the individual's primary care physician that Aricept, Namenda, et cetera, weren't good for people with Down syndrome, and what would be a good course of action to, quote, slow the progression.
Yeah, that's a challenging question. The medications that we have had up until just recently have not been shown really to be that beneficial in people with Down syndrome. Unfortunately, the memantine, the Namenda, and the Donepezil, the Aricept, they really have not been shown to be beneficial, and that's been our clinical experience as well. We have on our website lots of information about possible prevention methods, exercise, healthy diets, etc. We don't have definite proof of that, but we do have some suggestion that might be helpful. And then lastly, there are some new medications that seem to have much more promise. Unfortunately, they were not studied in people with Down syndrome. That's what I referred to earlier. And there's really a big push with the FDA right now to get these studied in people with Down syndrome and other intellectual disabilities to know that they're safe and presumably effective. And so limited information at this time, but it's changing rapidly.
Great, thank you. we're going to be running over if we don't. Catherine, do you want to go to the resources and also comment? There are some questions we haven't answered, information and how they can have those, who to forward them to and how to, and also the links. So if you want to go with the resources.
Sure. At the very beginning, Dr. Bishop mentioned a couple of books by Tom Kitwood, or mentioned his model of person-centered care. If you'd like to learn more about person-centered care, these two books are available. Also the NTG, that's our website there. We have lots and lots of information on the website specific to intellectual disabilities and dementia. We invite you to take a look at the page, and the NTG early detection screen for dementia, which doesn't have to be done by a clinician. Family members can do it. It's being used all across the country, internationally, actually. You can get information on that there as well. If you have questions that were not answered from the webinar, Kathy and my emails are right there on your screen. And we would invite you to email us your questions, and we will pose them to our participants, to our panelists after the fact, and get those answers back to you. So those are our emails, and I'll put them. Kathy, would you put our emails in the chat box while I continue to do this?
Sure. And would you also comment on how they can get, I don't know if Janine has answered it, but the link for contacting Janine about her support group?
Kathy, I put it in I answered Sarah's question in the Q&A, and I also just put it in the chat.
Perfect, great. I just wanted to make sure. Great, thank you.
I do highly recommend JD's Facebook group to any families that are out there. I don't know how many folks you have on your list now, but it's a very large number, I think.
It is.
And it's a fabulous resource.
It's over 1,000, and just so people know, we are very particular about our membership. We have families that come in there and say, you know, they have somebody that's 18, and we respond back to them and say, please go back to your doctor and ask them to do some more testing, because that's not what we're seeing, you know, but the experts are not seeing that. Research is not showing that folks with Down syndrome have Alzheimer's at 18. That being said, we have gone, since Christmas time, we have gone over 1,000 members. It's primarily parents and siblings who are caring for loved ones. Got a few extended family members caring for their loved one, but we also have professionals, you know, people who are providing community services. Dr. Keller is on it. Kathy and Catherine are both in it. And I love that part of it, because when it's necessary, we can get a really well-rounded perspective on a person's question. And it's a very active group. But we do have a questionnaire that you must complete for us to grant you membership in the group, because it's not a teaching tool. It is a support group for families who are anywhere on the Alzheimer's journey. And sadly, many of them are in their last days, and there are some pretty significant posts that go back and forth. And I just do not want people that are just kind of curious in the group. So I'm very protective of my members.
Thanks, JD, and great resource. And also wanted to call out Dr. Chacoin's Advocate Medical Group Adult Down Syndrome Center Resource Library, where you will find articles on all sorts of topics and video. Highly recommend that as well. And again, you know, thanks everybody. I'm going to put the link up for the post-test here in 1 minute, and I will also put the link in the chat box, and I'll leave it up for a couple of minutes. So while people are doing that, again, on behalf of Kathy and Lori and I just want to thank you all so much. This has been a really rich conversation, and I took away lots of grist for my mill, as I know JD did and others did. So I thank you all so much for taking your time today. We greatly appreciate it. And we hope to be talking to you all soon. And thank you to everyone who took the time out of your busy schedules to attend. And we'll be sending out the link to the recording within a couple weeks, and it will be posted on ONEgeneration's website if if you'd like to look at it again there. So thank you,
Thank you all.
everybody.
Thank you very much.
I'm going to leave the screen up for a couple minutes for folks to get to the link, but everybody else, I guess we're class dismissed.
Brian, Anne, Jadine, and Jim, your anxiety was unfounded. Fabulous, fabulous webinar. Thank you so much for all you gave to all of us today.
My
Thank
pleasure,
you.
truly.
Oh, and people are saying the link isn't working. I'm not quite
Yep,
sure what that's
try-
about.
Yeah, try it again. I think it's because everyone's trying to get in at once. Should be fine. I have it open right in front of me here, so it should be. I don't see any reason why it isn't working.
It says something about needing permission.
Nope, it shouldn't. Try it again.
No, it's working now.
I think everyone
No, try
other
it
than,
again.
yeah, okay.
Yeah, I just want
The
to say,
few of us, yeah, it can go off, including interpreters. Wonderful job. Sorry, I didn't thank you before. Great, great work. Pleasure to work with you as always, both of you.
I'll stay on for a couple of minutes for folks. The link is in the chat box. Just scroll back up towards the top. If you didn't see it, I'll try and get it in here again, but it's up there, just a couple of comments above.
Yep, and I'll stay on with you. I can't, I'm overwhelmed by the interaction. I didn't think we'd have enough to fill time, and we couldn't get everything in. So, but I guess leave people wanting, and maybe we need to do a part 2 sometime. Excellent work. Thank you.
Yeah, this was amazing. I thanked everybody, the panelists in the chat, but this was, I think, one of the best webinars we've ever done. This was, and I really, really am so grateful to each and every one of you.
It was
Yeah,
fun.
I'm so grateful you were there, because this was the hardest to organize and to think about how it was